In the second part of this lecture, let's try to discuss some of the common questions that you will come across during rounds when you choose one fluid over the other. There are different clinical conditions which you will need to individualize based on your patients, and you will need to pick and choose, judge what was the best thing to do for your patients. The first most common question that I will be discussing is, will you be using normal saline or lactated drinkers? Now, let's try to understand this. As I told you before in this chart over here, is that normal saline has a higher amount of sodium and chloride as compared to your plasma, whereas the balanced crystalloids like lactated drinkers and plasmalite have almost similar concentrations of sodium and chloride as compared to plasma. The problem with lactated drinkers is that although its osmolality is very similar to that of plasma, but it's slightly hypoosmolar. It's 273 as compared to plasma, which is 275 to 295. Plasmalite, on the other hand, is 295. The problem with plasmalite is that it is not very commonly available in all the hospitals, and it is also more expensive as compared to lactated drinkers. So when you use balanced crystalloids, what we'll be mainly talking about is lactated drinkers. The trials which I'll be discussing, some of them have used plasmalite, some of them have used lactated drinkers, and some of them is a mix of both. So this is the main difference between the two. Now, what happens when you use normal saline? Normal saline has a higher amount of chloride, as I said, and as I'll be discussing more in my future lectures on acid and base imbalance, is that normal saline is one of the commonest cause of non-anan gap metabolic acidosis, that is hyperchloremic metabolic acidosis, which is one of the commonest causes of NAGMA, that is non-anan gap metabolic acidosis. Also, in cases of AKI, the clearance of this will be lower, and hence you have a higher chance of inducing metabolic acidosis if you use large amounts of normal saline. Lactated drinkers, on the other hand, is balanced and it doesn't cause hyperchloremic metabolic acidosis. The problem with it, as I said, is that it's slightly hypotonic and hence you will not be using it in cases of cerebral edema. If the patient has a stroke and you risk cerebral edema in them, you will not be using normal saline. If the patient has traumatic brain injury, if the patient, whenever you think that there is a chance of having cerebral edema, you will not be using lactated drinkers. Some of the common myths associated with lactated drinkers is that it has a very high potassium and hence you cannot use it in hyperkalemia. Now, as you see over here in this chart, I told you before that you only need to remember a few things when it comes to these concentration of different ions, is that potassium in lactated drinkers is only 4 milliequivalent. So you need to remember that to bring the potassium up in a patient's when you look at the patient's lab, let's say somebody's potassium is 3.2. Now, to bring it up to 3.3, that is 0.1, you need to give 10 milliequivalent of potassium, which you must have experienced. If you recently joined your residency program, you would know when in the morning when your senior resident or the attending asks you to replete somebody's electrolytes, you will be giving somebody potassium and you always ask how much you want to give. So if you give 10 milliequivalents, approximately the potassium is going to go up by only 0.1. So if you give somebody 1 liter of lactated drinkers, it only has 4 milliequivalent of potassium, which is nothing. So you have to give 4 liters to give somebody 40 milliequivalent of potassium, and it's only going to increase the potassium by 0.4. So again, let me repeat this. The potassium will go up from 3.3 to 3.4 if you give 10 milliequivalent. If you give 40 milliequivalent, it will go from 3.3 to 3.7. So in order for you to actually raise somebody's potassium by 1, you need to give them 10 liters of lactated drinkers, and you will rarely give this much amount of fluid to anybody. So this is one of the commonest myths that associated with lactated drinkers, is that you cannot give it in the patients who are hyperkalemic. On the other hand, what you need to understand is that if you give somebody large amount of normal saline, you will induce metabolic acidosis, and that will actually cause hyperkalemia. So this is one of the things that you can discuss during the rounds. If somebody ever tells you that, okay, you cannot give it, you can give this rationale, and there are multiple studies available which show that there is no such basis to not give somebody lactated drinkers just because they are hyperkalemic. It's very minimal. Another thing, one of the misconceptions when you join your residency when you're new in the hospital is about lactic acidosis. Now remember that lactated drinkers doesn't have lactic acid; it has sodium lactate. These are two different things, and so it will not worsen somebody's lactic acidosis if you give them lactated drinkers. Since sodium lactate is metabolized in the liver, a lot of people will say, okay, somebody is having any liver dysfunction, you will not give them lactated ringers. What you need to remember is that lactated ringers you will not give only when somebody has acute liver failure. If the liver shuts down, patient goes into complete liver failure, that's when you will actually avoid lactated ringers. Otherwise, there's not much difference. If somebody has chronically mildly elevated liver enzymes, transaminitis, lactated ringers will not make a big difference unless they go into acute liver failure. Two other important places where I would recommend you could avoid lactated ringers is that metformin-induced toxicity, metformin toxicity, and metformin-associated lactic acidosis. That's where you will avoid lactated ringers. And also, lactated ringers has calcium in it, and hence, in cases of severe hypercalcemia, you could consider avoiding lactated ringers. Otherwise, lactated ringers is a balanced crystalloid, and it's always going to be better when you use it, especially for resuscitation, as compared to normal saline, in my opinion. Now, there are multiple studies that came up showing that which fluid will you pick between normal saline and lactated ringers. A lot of attendings will have different opinion about these two, and you could try to practice and see what works the best. But I'll be discussing some of the evidence that we have in short, and you can go ahead and discuss these studies when you have your journal clubs and see which fluid you will pick one over the other. But in my opinion, personally, every fluid that you pick is based on the patient itself. There's a chance that one fluid will work for someone and it won't for the other. But let's discuss some of the evidence that we have. So the two recent studies that we had on when they compared balanced crystalloids with normal saline is the PLUS trial and the BASICS trial. Both of them did not show any difference in the 90-day mortality in the critically ill patient. The PLUS trial also did not show any difference in acute kidney injury when they compared plasma-light versus normal saline in critically ill patient. A trial before that, the SMART trial, showed some statistically significant difference when it came to major adverse kidney events at 30-day, which included mortality, renal replacement therapy, and persistent renal dysfunction in critically ill patient. And there was a difference, and there was higher major adverse kidney events at 30 days with normal saline in the SMART trial. But again, it was a 30-day outcome. Whereas if you compare with the most recent studies, the PLUS trial and BASIC trial, they compared the 90-day mortality. Then coming to the SPLIT trial, which also did not show any difference in AKI between normal saline and balanced crystalloid at 90-day in critically ill patients. Then we had a SALT ED trial, which was done in non-critically ill patient, but it was a single center trial, and there was no difference in the hospital-free days, but the major adverse kidney events at 30-day was lower with balanced crystalloids. So as you see, although the mortality is not much different when it comes to using between normal saline and balanced crystalloids, you should rather prefer to do an individualized approach. Like, for example, let's say now your patient is at risk of developing hyperchloremic metabolic acidosis, or they have hyperchloremia at baseline. You would avoid using normal saline, although there is an argument that there is no difference in the mortality, but you would use an individualized, or what we call nowadays as the pH-based approach. If somebody, on the other hand, is alkalotic, you would actually prefer, or hyponatremic, you would actually prefer using normal saline over lactated ringers. So you have to pick and choose between, and every patient, every case you come across in the hospital is going to be different. You're going to use logic and reasoning and see which fluid is going to be the best. So if the patient has AKI, they have a lower clearance as compared to a normal patient, they have a higher chance of going into acidosis, you would prefer using balanced crystalloid like lactated ringers rather than normal saline. On the other hand, if these conditions do not exist, you know that there is not much difference, then you could use either one of those. And if somebody is alkalotic, you would actually prefer normal saline over lactated ringers. So I will be discussing these topics in more detail when I discuss acid-base imbalances, and you would understand how metabolic acidosis, metabolic alkalosis, then respiratory acidosis, respiratory alkalosis, in which condition, if some patient is compensated, not compensated, which fluid will be the best for them. But for now, this is something that you should infer from this discussion, is that although there is no difference, much difference in mortality, there is a chance that although there's no difference in mortality, a lot of consultants now go for pH-based decision making, and also depending on how the patient would react to one or the other fluid. So in the end, what I would like to say is that you could use a normal saline or lactated ringer for resuscitation. And then coming to the maintenance fluid, the drip that you would be starting, a lot of times you would prefer using D5 half normal or half normal. As I said before, normal saline, if you use a liter, it has almost 9 grams of sodium. So if somebody has hypertension, heart failure, they are at risk of having high blood pressure, diastolic dysfunction. In all these cases, you would prefer not using a lot of normal saline for them just for maintenance. So D5 half normal, half normal. In some patients who have a higher ongoing losses, as I said over here, when we discuss the maintenance fluid, if somebody has more ongoing water and electrolyte losses, if somebody came in with DKA or acidotic, have a baseline high deficit of volume in their body, you would use higher rates than what you have calculated. And in those cases, you could also use lactated ringers if you're not using half normal. So it's more of something that you would prefer. So it's more of something that you learn with practice. There are not fixed guidelines about how you're going to use your maintenance fluids, but something that you have to keep in mind about the patient's electrolyte status and volume status, how they reacted to resuscitation fluid, where you expect them to go in the clinical course. So this is something. Now, another common question that you will come across is, will you use crystalloids or colloids? Colloids mainly includes the blood products, platelets, FFPs, which you will of course use when you want to give somebody these products. Let's say if somebody has a hemorrhage, if somebody has GI bleed, hemorrhagic shock, in all these cases, of course, you're going to transfuse blood. But what about the solutions like albumin, 5% albumin, which has an osmolarity about 309, and 25% albumin, which has an osmolarity of about 312. Now, remember these compartments again, as we discussed in the last part, is that whenever you give somebody colloids, they mainly stay for a longer time in the intravascular compartment, whereas crystalloids will be distributed between the interstitial and the intravascular compartment. So if you give a liter of albumin, it's going to mainly remain in the intravascular compartment, whereas a liter of normal saline or balanced crystalloid, like for example, lactated ringer, it's going to redistribute itself with 800 ml in the interstitial and 200 ml in the intravascular. So if you look at it, if you were trying to resuscitate someone, colloids will remain in the intravascular compartment longer, right? But there are certain things that you have to consider before using colloids. One is they have a high oncotic pressure. The other one is they're expensive. And the other thing is also that they're immunogenic. Now, theoretically, if somebody is in septic shock, for example, they might have a high capillary leak, and hence these proteins will leak out of these capillaries going into the interstitial space, bringing in the fluid with them. So what did the study show that when you try to choose between, let's say if you're trying to use normal saline or lactated ringers versus colloids to resuscitate someone? The most recent study that we have is the SAFE study, which was done between 4% albumin versus a crystalloid normal saline 0.9%, and it did not show any difference in the all-cause mortality at 28 days. Now, these included all the adult patients who were admitted to an academic tertiary center ICUs who were judged to require fluid administration to maintain or increase the intravascular volume. It excluded the post-op cardiac surgery and liver transplant and burns patient. It also did not show any difference in the ICU length of stay, duration of mechanical ventilation, or renal replacement therapy. It actually was associated with higher mortality. It showed that the albumin was associated with higher mortality in head injury patients who were resuscitated with colloids in the 4% albumin group. The subgroup analysis of this trial in cases of severe sepsis showed some benefit of using albumin in cases with severe sepsis. However, this was not statistically significant. So what we infer from this trial is, although there's no difference in the all-cause mortality between using crystalloids like normal saline versus colloid like albumin at 28 days, you have to remember that it showed higher mortality, statistically significant higher mortality in head injury patients, and hence colloids should be avoided in the patients with traumatic brain injury, head injury. When it comes to sepsis, we need further studies in the patients who are septic and the use of albumin in them, because in this study there was no statistical significance between the two, although the the albumin did show some degree of benefit in cases of severe sepsis. So a lot of times, some experts might tell you that you could use albumin, but again, we need further studies to actually say that there is some benefit. The Albius study, which was done between 20% albumin with crystalloid versus crystalloid alone, with the goal of keeping the serum albumin more than 30 gram per liter in the albumin group, also did not show any difference in the mortality at 28-day or even at 90-day. There was another trial in the past, which was crystal trial, that is the crystalloid versus all the colloids, including hetastarch, gelatin, and albumin, did not show any difference in the 28-day mortality or renal replacement therapy, but it had a lower 90-day mortality with colloids. Colloid group also had more days free of mechanical ventilation and vasopressors. The problem with this, the limitation of this trial was that due to the heterogeneity of this trial, the lengthy study period, open label. So that's the reason that we now go with the results of the SAFE study. And also we all have a 6S trial, which was done in the patients with sepsis and showed that 6% hydroxyethyl starch, when it compared with lactated ringer, it was associated with higher risk of death and renal replacement therapy. So if your hospital does have hydroxyethyl starch, remember that you should not be using it in sepsis because of the higher mortality. Then the available KDIGO guideline says that in the absence of hemorrhagic shock, you would use crystalloids as the initial management in the patients with at risk or with AKI. So in the end, what I would like to say is, in my opinion, although there's not much difference in the mortality when you use crystalloids versus colloids, you have to remember that you have to use an individualized approach. The first line, you can start with crystalloids, and eventually colloids can be second line of resuscitation. Nowadays, the use of colloids, that is the albumin solution, is mainly limited to SBP, hepatorenal syndrome, and large volume paracentesis. Otherwise, there's not much evidence that use of albumin for resuscitation is better than crystalloids. It is expensive, it is immunogenic, has high oncotic pressure. So you can stick to crystalloids unless the particular condition requires you to use albumin. Then the other important thing that you must also remember that, of course, albumin you will not use for maintenance fluids. And these all discussions that I'm doing when it comes to crystalloids versus colloids is related to resuscitation fluids. Now let's talk about IV fluids and sepsis. The surviving sepsis guideline states that early fluid resuscitation has to be done with at least 30 ml per kg unless the patient has significant pulmonary edema. Now, we had some studies in the past, some observational studies that showed that giving the patient huge amount of fluids, especially in sepsis, was associated with poor outcomes. So we have two major trials that I'm going to discuss here that was done between giving someone restrictive fluids versus giving liberal amount of fluids, and what were the outcomes. So the first one is the classic trial that was done between liberal fluid use versus restrictive use in septic shock. Now the liberal fluid group had a standard amount of resuscitation fluid given, plus replacement of the overt and ongoing losses, plus giving them some maintenance fluids. Whereas the restrictive fluid groups had fluid given only for severe hypoperfusion and the replacement of the overt losses. Now, fluid restriction in this trial did not show to result in fewer deaths at 90 days as compared to the standard therapy of giving somebody fluid resuscitation and keeping them on maintenance if needed, and replacing the overt and ongoing losses. And the problem with this trial was that approximately 3 liters of fluid was given in each group in 24 hours prior to randomization. So the total difference of the fluid that was administered by day 5 was only about 2 liters. So we have one more trial, the most recent one, about discussing this topic between use of restrictive fluids versus liberal fluid, and that is the Clovers trial, which used early restrictive fluid with early vasopressor usage versus liberal fluid. And again, even it did not show any difference in the mortality by day 90. So what is it that you should really do? Should you give a patient with septic shock a large amount of fluid or no? The answer is that, again, it's an individualized approach. You will first resuscitate someone based on the standard surviving sepsis guidelines by 30 ml per hour. You will reevaluate the patient to see if more fluids are needed. and then you would also supplement with pressor support. Now, in my personal opinion, a lot of times you will see when you are new in the ICU, you have your first or second ICU rotations, you would see that a lot of times it's possible that somebody would start the patients on pressors early on in the course of the ICU admission. Now, something that you have to remember over here, if you evaluate a patient, if they're significantly hypovolemic, especially in the patients who are septic, if they're hypovolemic, dehydrated, now, these patients, if you start them pressors without adequate resuscitation, there is a chance that you would cause more harm. Because remember, giving somebody pressors without you adequately resuscitating them, it's like you're trying to replace oil in your car when it ran out of gas. So you should fill up the tank first, make sure that the patient is adequately resuscitated. I already discussed before that what are the different parameters you could look at to see if the patient is going to be fluid responsive or not, if they need more fluids or not. So if the patient is not on the vent, you could check their IVCC, if it is, how is the diameter, if it is distended, if it's collapsible. And then if the patient has a central line, internal jugular, you could check their CVP. You could look at the other labs after you initially resuscitate them, see if they need more fluids. If the patient is dry and you prematurely start pressors on them, there's a chance that their liver enzymes are going to rise, their kidney, you're going to cause vasoconstriction throughout the body, causing elevation of the creatinine. So these are some of the things that you have to remember. If the patient is already on the vent and went into septic shock, again, as I said before, there are different maneuvers that you could do, and you could check their pulse pressure variation, stroke volume variation. You could check their IVC distensibility index, and all these things will help you decide if the patient needs more fluid. If the patient is not improving after fluids, you could definitely add pressors to them. So it's more of an individualized approach. A lot of times different consultants will have a different way of doing things. So you could practice this and learn what works the best for that particular patient. Then coming to IV fluids and pancreatitis. Now, remember that, as I said, that a lot of observation studies and a lot of studies have shown that using huge amount of fluids can cause poor outcomes. But in case of sepsis, when these two trials showed that there is not much difference, we came to the conclusion that you would use the fluids based on how the patient is responding. If the patient needs more, you give it. Otherwise, there's no need to drown the patient in huge amount of fluids. But at the same time, you would not keep them fluid restricted early on in the course and see and judge based on individual patients. Similarly, in pancreatitis, now what you have to remember is that the guidelines have changed, and now we use 10 ml per kg of resuscitation fluid. Why is that? Is based on this trial, the Waterfall trial. So the choice of fluids in pancreatitis, when you admit the patient, you know that one of the main modalities of management in pancreatitis is fluid resuscitation, and the choice of fluids is lactated ringers. This is based on some limited amount of evidence that lactated ringers is better to reduce the systemic inflammation. And we have the most recent Waterfall trial published in 2022, which compared aggressive fluid resuscitation versus moderate fluid resuscitation. And they found out that using moderate fluid resuscitation was associated with lower chances of volume overload. And this trial was done mainly in mild pancreatitis patients. So now this is something that you have to remember. If this trial ever comes up when you're discussing during the rounds, remember that this trial was done mainly in the patients with mild pancreatitis, and patients with moderate to severe pancreatitis were excluded. That is, those who were in shock, those who were in renal failure, and those who were in respiratory failure. If you have heard my previous lectures, I always say, whenever you're using an evidence in a particular patient, whenever you're using a trial, the data from the trial on your particular patient, you have to make sure that you know the inclusion and exclusion criteria and whether or not this patient fits in the inclusion criteria of that trial for you to implement those results. So same thing goes over here. In the Waterfall trial, which was done in pancreatitis, it was mainly in mild pancreatitis. And then the aggressive group, they gave 20 ml per kg of bolus. And then after that, they kept them on 3 ml per kg per hour of infusion for 48 hours. In moderate fluid group, they used 10 ml per kg of bolus if they were hypovolemic. And after that, they kept them on 1.5 ml per kg per hour of infusion for 20 hours. They found that there was increased chances of fluid overload in the aggressive group, and there was no difference in disease-specific outcomes, that is ICU admissions, development of severe pancreatitis, death, local complications, and organ failure. So what would you do now? What is the bottom line for this is that you would start the patient with 10 ml per kg bolus, as are now the guidelines for management of acute pancreatitis. And after that, you could keep them on 1.5 ml per kg per hour of infusion. You could reassess the patient at frequent intervals in 4 to 6 hours. You could repeat the labs. You could do the patient's clinical exam. You could see in which direction the hematocrit, the BUN, and creatinine are going, if the patient's tachycardia is improving or not. If there is a change in the BUN since admission, this also gives you a sign that the patient is responding and what you did was right. If not, then you could give the patients more fluids, in my opinion. Remember that not every patient with acute pancreatitis is going to come to you with the same level of volume status. Some might be more drier than the others. And hence, if you're using 10 ml per kg, there's a chance that some of the patients might still be dry. So it's based more on the patients. Again, as I said, as I discussed the previous conditions, nowadays you would reassess, and then not one rule is going to work for everybody. So you would reassess and see if your patient needs more fluid, if their symptoms have improved, if their labs are going in the right direction, then yes, you would not use a lot of volume to avoid volume overload, to avoid pulmonary edema. But if they are actually still dry after using 10 ml per kg, then yes, you would definitely give them more fluids. Now, coming to one of the next condition where IV fluids are one of the main parts of management is DKA. So in DKA, there are three important things. One is the fluids. You will give a lot of fluids. The patient is in a huge amount of deficit. Then you would use insulin. At the same time, start the patient on insulin drip, DKA protocol. And then at the same time, you have to remember the guidelines for resuscitating, for replenishment of potassium. Now, what would you use in DKA? Would you use normal saline or lactated Ringers? Now, one important thing that I would like to discuss over here, which I'll be going in much more detail, is in my acid-base lecture, is about calculation of the delta ratio. Now, what is the delta ratio and what does it tell you? When you calculate someone's anion gap and you look at the patient's bicarb, you could get the delta ratio out of it. That is the delta anion gap, which is anion gap minus 12, and the delta bicarb, which is 24 minus bicarb, and you would get the delta ratio. If the delta ratio is less than 0.8, it means that the patient has anion gap metabolic acidosis and non-anion gap metabolic acidosis. If the delta ratio is between 0.8 and 2, that means the patient has pure anion gap metabolic acidosis. If the ratio is more than 2, then that means that the patient has anion gap metabolic acidosis and underlying metabolic alkalosis. So what it tells you over here is that this ratio will help you judge which fluid to pick. As I said before, normal saline is associated with hyperchloremic metabolic acidosis. So if the patient's delta ratio is less than 0.8, you would want to avoid normal saline because you would push the patients towards more of NAGMA, and hence you would pick LR in these cases. When it's pure anion gap metabolic acidosis, you could pick either of these two. And when it's actually the patient is having underlying metabolic alkalosis, if the delta ratio is more than 2, you would prefer using normal saline in these cases. So again, as I said, there are not fixed guidelines about what you want to use. You could pick and choose based on how the patient is. Also remember that you have to look at somebody's corrected sodium. If somebody is having hyponatremia, then yes, you could definitely go for normal saline as well in those cases. Now, how much fluid would you want to give a patient with DKA? Now, you would do initial resuscitation. As I said, you could start with 20-30 ml per kg, assess the patient's volume status. You could start bolusing them 1 liter per hour, and then you could give 30 ml per kg of resuscitation fluid as bolus for a couple of hours, and then you can reassess their volume status. If they are dehydrated, you would give them more of resuscitation fluid. If they are improved, then starting with the maintenance fluid, you would check what their sodium is and you would switch it to lower rates. If the patient is hyponatremic, then of course you would use 0.9% normal saline. You could run 250 to 500 ml per hour for a couple of hours. If the sodium is normal or if they have high sodium, then you would use half normal saline. about 250 to 500 ml per hour. Now, as I said before, the maintenance fluids and resuscitation fluids are different calculations. In maintenance fluids, as I said, usually D5 half normal is used. But again, remember, half normal saline and D5 half normal saline can worsen someone's hyponatremia. So you have to you would avoid using that in these cases. So based on this sodium, you could consider using normal saline versus half normal saline for maintenance fluid. And at the same time, you would have to keep an eye on the patient's blood glucose, because as I said, the three important modalities of management, one of them is insulin drip. If you started insulin drip in a patient with DKA, their blood glucose is going to start coming down. And once the blood glucose is less than 200, you would add D5 to the drips, whatever you're using. If you reached here, if you've adequately resuscitated them, and if you've switched to half normal, you would consider adding D5 half normal. If the patient is hyponatremic and you're still using normal saline in them, you would add D5 to normal saline or D5 to LR based on their blood glucose. Again, when you're trying to bridge the patient with DKA, if they're having a good oral intake, their gap has closed, and then you're trying to give them food, they're able to eat and drink, you bridge them with long-acting insulin. In those cases, you would eventually want to lower the rates and discontinue the fluids, the maintenance fluids. So as I said before, when we were discussing the calculations of maintenance and resuscitation fluids, not everybody will require the same amount of maintenance fluids. Some might require higher, some might require lower. It all depends on the patient. If the patient is oligouric, if the patient is not making any urine, of course, the maintenance will be lower for them if they're not having any ongoing water and electrolyte losses. And for some who have higher losses, then in those cases, the maintenance can be higher, like I said, in DKA. So it all depends on which patient you're treating and how their volume status is changing as the disease progresses. So this is for DKA. Now, talking about IV fluids and heart failure. Now, remember that in the clinical setting, all the patients that you see, most of the times you will not have just one particular condition. A patient with heart failure can present with sepsis. A patient with heart failure having low ejection fraction can present with GI bleed. Let's say if the patient is having history of atrial fibrillation, HFrEF, they are on DOACs, they're on warfarin, they might present with GI bleed. You might require resuscitation in them. The patient with heart failure can have a history of diabetes type 1 and can present with DKA. The patient with pancreatitis can have a history of heart failure. So a patient can have a mix of multiple conditions, and usually in the critical care settings, you would see more than one organ is affected. And these are the cases where you have to judge what is it that you're going to do. Now, coming to in these cases for IV fluids, let's say if the patient is having HFrEF. Now, one of the common misconceptions is that the patient who is coming in heart failure, who is either overdiuresed or dehydrated, is hypovolemic. A lot of times there's a common knee-jerk reflex in restricting these fluids because we always fear that they will go into pulmonary edema because they are heart failure. EF is 10%, 20%. So one thing that you have to remember, that if the patient is having heart failure, their pump is not functioning. In the previous lecture on heart failure, as I said, the concept of pump, pipe, or the tank and the pressure in these pipes, you have to remember, if as a normal person, now let's say if a young patient has a normal heart with an ejection fraction of 55 to 60% versus if the patient is having a weak heart with an ejection fraction of 10%, the patient with the weak heart, if that patient becomes dehydrated, if it has GI bleed, if it's septic, they will have much more poor outcome as compared to someone with a normal heart if they have a GI bleed or are septic or are dehydrated. So that's why you will not devoid these patients of IV fluids just because they have a history of heart failure. The maintenance fluids in these patients, of course, it's going to be less as compared to a patient who does not have heart failure, but resuscitation can be more or less the same. You would definitely resuscitate them. A lot of times you would see that the patient, you discharge them on oral diuretics. They might go home not being able to drink much water. And a lot of times their response to medication changes over time with the renal function. They might sometimes present, or sometimes they might take more than needed of diuretics and become over-diuresed, dehydrated, and end up in the hospital with altered mental status, signs of shock. So in all these cases, you would definitely adequately resuscitate them before you do something else. So you also have to remember that there are some studies available which have shown that in the patients of CHF who presented with sepsis, physicians hesitate to administer liberal amounts of fluid according to the guidelines, that is 30 ml per kg. And it was found that in the patients who underwent fluid restriction in cases of heart failure and sepsis, the mortality was much more higher in the cases of fluid restriction than that as compared to liberal resuscitation. Although at the same time, in the group with liberal resuscitation, they required more endotracheal intubation, but the mortality in the fluid restriction was higher as compared to liberal. So if a heart failure patient, you resuscitate them, there's a chance that they might require endotracheal intubation. But if you restrict fluids, especially in the cases of sepsis, there is a much more higher mortality. So you have to, it's a tricky, these are kind of tricky cases. The patients are really sick in the intensive care units, and sometimes the decision becomes difficult to decide whether or not you want to give more fluids or not. But again, as I said, there are multiple modalities that we have for you to judge. If you could use a dynamic measure of fluid responsiveness, you could use that. If the patient has a central line and arterial line, if you can connect the patient to the flow track, you could check their stroke volume variation, pulse pressure variation, and see if they need more fluids or not. In cases of cardiogenic shock, a patient can require right heart cath, which I have discussed before. And in those cases, by using a swans, you would be able to get more idea about the volume status and see if you want to give more fluids or not. But either way, as I said before, prematurely starting pressors in the patients who are not adequately resuscitated, including heart failure, is like changing oil in a car that ran out of gas. So first you will fill up the tank, and then you would move forward with the management. Next, one of the other topics that are again challenging, like heart failure, is that the patients with end-stage renal disease who are not making any urine are dialysis dependent. Let's say if a patient comes to you is a 58-year-old, has multiple comorbidities, including heart failure, and they are also end-stage renal disease, dialysis dependent, either Monday, Wednesday, Friday, or Tuesday, Thursday, Saturday schedule. They come in because of septic shock. They can come in because of pancreatitis. All these conditions, it becomes challenging to manage. And then again, I would say resuscitation fluids you should not devoid the patient of resuscitation fluids. The maintenance fluids might be lower. As compared to a normal patient, you would want to keep a closer eye on their volume status. You might have to more frequently check them as compared to a normal patient in the critical care setting. But again, you would not restrict fluids in these patients, and it is associated with a much higher poor outcome. You could contact the nephrologist and see when you want to schedule the next dialysis with them in case if they become more volume overloaded. But you would definitely resuscitate them and can consider going on a lower rate or no maintenance fluid if they're not making any urine. Then coming to another condition where fluids is one of the main parts of management is that IV fluids and rhabdomyolysis. Now, in rhabdomyolysis, there is also the huge inflammatory state. There is muscle breakdown. The kidneys are at risk of injury, and you would do IV fluid resuscitation with 1 to 2 liters per hour until the creatinine kinase comes below 5,000. Now, the patients who are making urine, the goal urine output for you would be 200 to 300 ml per hour. If they are not doing this, you could consider giving more fluids. If the patient becomes oligouric, if they go into ATN, then if there is no improvement, even after 6 liters of fluid, then you could consider decreasing the fluid, and it would be better to call the nephrologist at that point to consider if the patient needs dialysis or not. Then in cases of volume overload, in rhabdomyolysis, you would definitely stop the fluids. As one important thing that you have to remember in rhabdomyolysis, there is severe third spacing, and it might give a false impression of volume overload. So you would mainly look for pulmonary edema, compartment syndrome as a better indicator of volume overload in these patients. Usually, mild to moderate cases of rhabdomyolysis usually respond pretty well to fluids. It is the patients with severe rhabdomyolysis where you could see the CK level go beyond 30,000, 40,000, a lot of times even on hundreds of thousands. Those patients are more difficult to manage because they also have so much inflammation, so much breakdown of the tissues that you would see a lot of third spacing when you're trying to give fluids. So these patients might need to undergo dialysis as well, in addition to resuscitation. Then one other thing in rhabdomyolysis that you have to remember is bicarbonate infusion, which I will be discussing in the next slide. You could use bicarb infusion in addition to the IV fluids if there is severe rhabdomyolysis with a pH of less than 7.5, bicarb less than 30, and the patient does not have hypocalcemia. Now, remember, the purpose behind using bicarb in rhabdomyolysis is not acidosis, it is to help alkalinize the urine. So this is something that you have to remember. You could use a separate IV and you could start the patient on bicarb infusion in case of rhabdomyolysis when these conditions are met in severe rhabdomyolysis. So it is also not very commonly you would see extremely severe rhabdomyolysis that is hard to manage. Most of the rhabdomyolysis cases are mild to moderate, but you have to learn how to use fluids in this condition. Talk about another topic, the concept of free water deficit. Now, the sodium concentration of your plasma is an indirect surrogate for the total body water. What that means is the total concentration of the sodium is not related to the sodium content. The content might be the same, but the concentration changes based on the free water in your body. So consider a tank which has salt dissolved in it, and you open the tap, which only allows free water to pass through it, and you will see that the concentration of sodium increases. So if the patient is hypernatremic, it gives an idea that the patient is in deficit of free water. And if the patient is hyponatremic, it gives an idea that the patient has excess amount of free water. So and if the patient is hyponatremic, that means the patient has excess amount of free water. Although this might not be always true, I will discuss in the future lectures about on hyponatremia and hypernatremia and how we manage them. What is acute hypo or hypernatremia? What is chronic hypo or hyponatremia? How are they different? Sometimes you will see that the patients who are dehydrated in the deficit of water and electrolytes, they might be hyponatremic and will respond to fluids. And sometimes you will see that the patient will have SIADH, be hyponatremic, and in those cases, you would actually treat them with fluid restriction. But otherwise, in the cases of hypernatremia, you have to understand what free water deficit means. It means that the patient will have the same sodium content and they will have the deficit of free water. So coming to the concept of free water deficit and the hypernatremia associated with it, you will commonly see this in the cases of ICU setting, especially when the patient is having large amount of insensible losses and they might lose more amount of free water and have hypernatremia. Now, how do you calculate someone's free water deficit for in order to you to correct it? Free water deficit will be equal to total body water times sodium minus 140 upon 140. Now, this total body water can be calculated with weight times the correction factor, which is different based on the sex and the age of the person. If you do not want to go into the details of these calculations, nowadays you have a lot of online calculators which you can go to, the apps on your phone. You can just put the patient's sodium, your required sodium, what you want them at, their weight, their age, their sex, and it will calculate the free water deficit for you. So either you could do that or you could have a simple trick which will give you an approximate value. For example, you could do the patient's current sodium, let's say it's 165 minus 140 divided by 3, and it will give you an approximate similar value. Let's take an example over here. If a 70 kg male comes in who is 40 years old, has a sodium concentration of 165, their free water deficit by this long formula will be approximately 7.5. And if you use the short formula, that is 165 minus 140 divided by 3, it will be approximately similar, that is 8.3 liters. So you calculated what someone's free water deficit is in the ICU, and now let's say you want to replace it. How would you replace it? There are two ways of doing that. Either you could do orally or you could do intravenously. Now, in the ICU, you must have heard about your intensivist talking about giving the patient free water flushes. Now, these free water flushes are something that help you prevent this from happening. Giving someone free water flushes is just like, let's say, a normal person is able to drink water. Now, when you drink water, you do not drink normal saline or lactated drinkers. You just drink the free water or simple water, which you could give to a patient along with the tube feeds that you're giving. So that is one way of doing it. And the other way is by using IV D5 water. Now, how much do you want to correct? Now, remember that in case of chronic hypernatremia, you will not suddenly correct someone's sodium, let's say from 165 all the way to 145 or 135 immediately, because this can lead to cerebral edema. So your goal of correction is about 10 to 12 or not more than 12 over a period of 24 hours. And how would you do that? Now, let's say for you to correct it about 10 to 12 over a period of 24 hours, your correction rate should be about 0. So if you want to correct about zero point 0.5 per hour, you would come to that how many hours would you need to correct this. Now let's say you need your sodium concentration to be 140, and right now it's 165. So 165 minus 140 upon zero point 0.5 will be equal to 50 hours. So for the same patient that we discussed above, if you want to correct somebody's sodium, you will require 50 hours with this correction rate so that you don't overshoot the goal and cause them to be at risk of cerebral edema. So 7.5 liters over 50 hours will be equal to about 150 ml per hour. Now, when you get this rate, remember that in the patients who are hypernatremic, you will have to frequently check their sodium, especially in the initial phases, at least every 4 hours, if not 2 hours, to make sure that their sodium is not correcting too rapidly. And you also have to remember, if you're starting simultaneously somebody on free water flushes with this IV rate, this rate might be lower. And at the same time, if the patient is having ongoing losses, so this is also something that you have to consider, that if somebody is having ongoing losses, the rate that you might need might be a little bit higher. That's the reason that when you start correcting somebody's hypernatremia, you have to be careful. And if you keep checking it every 4 hours, you will know that the rate that you have chosen is working or not. And if you need more free water flushes, or you want to lower the free water flushes in order to get a better control of this rate of correction. So these are something that you will judge with practice. If you're checking it every 4 hours, the more IC rotations you do, the more of these patients you see, you will know how to correct it. Now, remember that this concept is more related to chronic hypernatremia. In cases of acute hypernatremia that develops in less than 48 hours and is associated with severe symptoms, which you will see, like, for example, in case of diabetes insipidus, these concepts I will discuss in the future sections when I discuss the management of hyponatremia and hypernatremia. But over here, this what I'm talking about is the concept of free water deficit, which you will commonly see in the critical care setting in the patients who are having a lot of insensible losses, and if they are not getting enough fluids to replenish those losses. So this is something that you will keep in mind. And as I said before, when you're using resuscitation or maintenance fluids, the fluids might change from one fluid to the another depending on how the patient's electrolyte concentrations are, how the patient is reacting, what are their ongoing losses, what is their current volume status. So these things will change. Now, coming to the final part of the lecture, the bicarb drip or the bicarb infusion. Now, you must have commonly seen that a lot of times practitioners will quickly jump to using bicarb in the patients who are acidotic in order for them to fix the numbers. That is, for the acidotic patient, bring them to the normal pH. You always have to remember that you do not treat the numbers, you treat the patient. The reason I'm telling this is just using bicarb in an acidotic patient without figuring out is why the patient is acidotic in the first place is like giving somebody acetaminophen in fever, whereas they are septic, and you're not fixing the underlying problem by giving them antibiotics. So this is something that you have to remember. There are two important formulations of bicarb that we have: hypertonic formulation and isotonic formulation. Hypertonic bicarb is usually, but the most commonly that you will use is the 50 amp, 50 milliequivalent in 50 ml, the amps of bicarb, the osmolality of which is about 2000 milliosmoles. Then we also have 7.5% bicarb, 4.2% bicarb, but 8.4% is what you must have seen most commonly when you use amps of bicarb, that is 50 milliequivalent in 50 ml. The other formulation that we have is isotonic bicarb, which you can make by putting 3 amps of this 50 milliequivalent per 50 ml of bicarb in 1 liter of D5 water. That gives you a bicarb drip or isotonic bicarb drip, which is 150 milliequivalent in 1 liter. So these are the two common formulations in the hospital setting that you will be using. Now, when can you consider using bicarb in the patients? First of all, if the patient is having non-anion gap metabolic acidosis. Now, you would see a lot of experts and consultants would prefer using bicarb when the pH goes below 7.1 and sometimes below 7.2. So you would use it in non-anion gap metabolic acidosis, in cases of hyperkalemia, in cases of drug overdose, like for example, tricyclic antidepressants, alkalization of the urine, as I said before when I was talking about rhabdomyolysis, and in cases of uremic acidosis, especially if it is associated with hyperkalemia. You would see a lot of times in uremic acidosis with hyperkalemia, in order to delay dialysis, a lot of times some experts and nephrologists might recommend starting bicarb drip because this will give the kidney some time to recover, and you could in some cases avoid dialysis in the patients. Now, what would you use? Would you use a bicarb drip or would you use amps of bicarb? Now, something that you have to remember, that the amps of bicarb, ampules of concentrated bicarb, 8.4%, are very hyperosmolar. So there's a high chance that you could trigger hypernatremia by giving a lot of ampules of bicarb, and you would cause the drag of fluid from the intracellular compartment into the extracellular compartment. Also, 8.4% bicarb amps usually do not have a lot of effect on the serum potassium. So if you're trying to give it for severe hyperkalemia, you would prefer giving them isotonic bicarb, which helps you reduce the potassium by shifting the potassiums back into the cells. The 4.2% bicarb which has an osmolality of about 1000, will cause a mild decrease in the potassium. So this is something that you have to remember. In treatment of hyperkalemia, you would prefer using the bicarb drip rather than amps of bicarb. Now, where is it that you will not use bicarb? The most important place where people prematurely jump to giving patients bicarb is ketoacidosis. Remember that in ketoacidosis, especially diabetic ketoacidosis, they do not benefit from bicarb therapy. You have to remember that treating the ketoacidosis itself, let's say by in diabetic ketoacidosis, by giving more insulin, is what is going to be more helpful rather than giving them bicarb drip. Lactic acidosis also does not benefit from bicarbonate therapy. And again, you have to find out what is the underlying cause of this lactic acidosis and then treat it. In lactic acidosis, you will definitely not give bicarb unless the pH is less than 7.1 and is associated with either uremia, AKI, or non-anion gap metabolic acidosis. Now, in cases of cardiac arrest, you should not be using bicarb drip unless the cardiac arrest is due to a drug overdose, like, for example, tricyclic antidepressant poisoning, or in cases of hyperkalemia. When you know that if a code blue was called, you look at the patient's lab, the patient has hyperkalemia, and you think that the patient had a cardiac arrest secondary to the electrolyte abnormality of hyperkalemia, then you can consider giving bicarb. But otherwise, AHA recommends against the use of routine bicarb in case of cardiac arrest. Bicarb administration in cases of cardiac arrest is actually associated with more harm than the benefits it does, unless in the other two conditions that I specified before, like, for example, causing fluid shifts and hypernatremia, causing hypocalcemia, and also due to unreliable ventilation, especially if you do not have an advanced airway. Now, one important thing that you have to remember is that giving somebody excessive amounts of bicarb will lead to the generation of a lot of CO2, which the patient needs to wash out. So if you're giving somebody bicarb before intubation, if the patient is acidotic and you intubate them, you need to give the patient some time for the CO2 to wash out. So if you intubate someone, give them sedatives, and the respiratory rate drops immediately, this CO2 will not be able to wash out and your acidosis will not correct if with the bicarb that you give. So either if you intubate someone right after giving bicarb, you have to make sure that you establish their respiratory rate on the vent settings almost similar to what they were before, or you give them some time, either 10 to 15 minutes before you actually intubate them, for the CO2 to wash out. Otherwise, the bicarb that you give, there's a chance that it will not help you correct their pH. Now, one important evidence that we can discuss over here is the bicarb ICU trial. Now, this trial was done on the patients who had metabolic acidosis with the pH of less than 7.2 and partial pressure of CO2 less than 45. The patients who were excluded were those who had ongoing losses of bicarb from the GI tract or kidneys, as in case of stage 4 CKD, ketoacidosis, or exogenous acid load, like, for example, in salicylate or methanol poisoning. The patients who were treated with bicarb was with 4.2% bicarb. Now, the included patients in the control arm did not get any bicarb, and the patients in the bicarbonate arm received 4.2% bicarbonate infusion in 30 minutes, and the blood gases was drawn. And if the pH was less than 7.3, more infusion of bicarb was given. If the pH was more than 7.3, the bicarbonate infusion was stopped. They found that there was no mortality difference in the end of 28 days in these patients. However, one of the positive things out of this was that bicarbonate reduced the need for dialysis in the patients who were given bicarb. Now, emergent dialysis is an invasive procedure and can cause numerous complications. So, the fact that bicarbonate reduced mortality among the patients with more severe kidney injury shows that avoiding dialysis might offer the patient additional benefit down the roads. Also, you should keep in mind that the Bicar ICU trial was performed on very sick patients within 48 hours of ICU admission, and this trial you need not necessarily use on a stable patient with chronic acidosis. Using Bicar ICU trial is not a justification to blindly start somebody on bicarb drip on every acidotic patient. So every patient is different, as I said, and you should use an individualized approach. So in the end, what I would like to say is, as I said before, that you would use a pH guided approach. And let's say if you have a patient who is acidotic, has non-gap metabolic acidosis, you would prefer avoiding normal saline in them. And if the patient's pH is too low, like for example, lower than 7.2, 7.1, then you would consider using isotonic bicarb for a while in these patients as maintenance fluids. Then, if the patient is having a normal pH and they do not have any underlying acid base imbalance, you can consider using balanced crystalloid, like, for example, lactated ringer or plasmolite. In the patients who have underlying metabolic alkalosis, on the other hand, you could consider using normal saline. So it's more depends on the patient, and every patient might be different. What rate of correction will you use with the bicarb infusion? There are no fixed guidelines. Usually you could consider using 100 to 150 ml per hour, and you could check their acid base status again with the help of ABG, and you could see in which direction they're going, if the underlying issue is being corrected or not. Again, I would say the most important thing in using bicarb infusion is you treat the underlying problem. Why is the patient acidotic? If the patient is having non-gap metabolic acidosis, why is that happening? If the patient is having hyperkalemia, why is that happening? All these conditions are something that you have to address first, treat them rather than just using a bicarb drip. Also, one very important thing that you would remember is that a lot of times the patient might be well compensated. So if you're doing an ABG, you know that the patient is acidotic, but they have compensated themselves and they have a normal pH, or they have underlying respiratory alkalosis on top of the non-gap metabolic acidosis. You would be very careful before using bicarb in these patients, because a rapid shift in the pH can cause rapid shift in electrolytes and can cause more harm than the benefit. So you would be cautious, although you would want to delay dialysis, and you can consider giving them bicarb drip, but you always have to be careful about what effect is it going to cause in the short term and the long term. So always think about treating the underlying problem. Like for example, if patient is acidotic, why are they acidotic? If the patient is hyperkalemic, why are they hyperkalemic? Does this patient need dialysis? Does this patient need some other treatment rather than just masking it with bicarb drip? It can help you, as I told you, in these conditions, and it has to be avoided in the other conditions like ketoacidosis, lactic acidosis, and cardiac arrest. So always remember to choose the best treatment for your patient, and every patient will be different. What one guideline might work for one patient might not work for the other. So that's it for this lecture. If you stayed this far, thank you so much for listening. In the end, I would say that all the discussions that I have done are my personal interpretation and my personal opinion based on what I have read. In the end, I would say that try to practice as much as you can. You would become better. You would know better with more experience you gain, especially in the critical care setting. You can discuss these topics. You could bring up these topics in your journal clubs, discuss them with the consultants, with the experts, with your attending, and in the end, decide what you want to do. These lectures are in no way meant for medical advice for the patients. Thank you so much for listening. And if you like this lecture, please like, share, and subscribe my work. Thank you.